Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune diseases. When I left off last week, I was speaking about white blood cell count when they become low in association with a disease that is of autoimmune nature. I copied to show you 10 pages of different autoimmune diseases that, that exist, and of course, there is no organ in the human body that has not been at one time or another associated with one form of autoimmune disease or another. As a result of that, this sheet I have in my hand that I copied showed different organs, all the different organs. You just name it. If it's on the human body, there has been an autoimmune disease associated with it. And all autoimmune diseases can be associated with low white blood cell count. All. Now, in addition to the statement that I just made, there is the issue of ethnic associated low white blood cell count. The subgroup of individuals in the world with the lowest ethnic associated white blood cell count happens to be blacks, Ashkenazis of different degradation. The median total white blood cell count in Caribbean blacks is 2,600. The normal white blood cell count is between 5,000 to 10,000. A very interesting and study was done at Columbia University School of Public Health in 2008. It was very well organized, very well done. The upshot of it is that that particular study documented that 25% of blacks in the United States have low white blood cell. You say, well, what is the big deal about low white blood cell? The big deal is that every single day that we get up, we are exposed to multitude of different microorganisms in the air, things that we touch, things that we eat, things that we inhale, that the body has to fight to keep us alive because we need the white blood cells. And there are different types of white blood cells. I thought I would take a little time to explain to you what the different types of white blood cells are and what they do. They're there to basically keep us alive by fighting microorganisms that is ready to attack us every single moment that we're alive. You have lymphocyte, monocyte, polysegmented white blood cell. Those are the main ones. You have band, those are early, and then those are cells that are in the circulation. Then when the bone marrow, the family of these red blood cells start out in the bone marrow where they are produced, and then they get released into the circulation. They are in the circulation. When we measure the white blood cell count, we are measuring those that are in the circulation. However, unknown to us, there are large quantities of white blood cells that are lining the wall of our vessels, sitting there, waiting to be called upon to attack a foreign microorganism that enters into the body to basically kill them, to keep us alive. And some of these white blood cells, in particular the lymphocyte and the monocyte, they also produce, in addition to that, they produce substances that help us to kill the organism in the process as well. The special stuff that they produce to help kill the organism. Now, when things happen to us by way of an infection, the first white blood cell the first white blood cell that's going to attack the microorganism that find its way in the bloodstream is the white blood cell that are in the circulation. And then if that's not enough, then the body demands the release of those that are lining the inside the blood vessel to come and join the fight to try to kill the microorganism to keep us alive. In addition to that, there are other mechanisms, two main mechanisms that is very important to remember. One is demagination, one is migration. Migration of white blood cell is when something happens, we need more white blood cell to get into the circulation to join the fight. There are mechanisms that exist in the human body that allows the migration to take place so that the body can stimulate the bone marrow to dump more white blood cell because the demand is there in the circulation. In addition to that, the quickest thing that happens is a process called demagination. I'm not going to sit here and bore you with my academic know-how to tell you the different things that can cause demagination to occur. That is very boring, high-powered academic stuff is really interesting to people like me whose life it is to deal with it. But for people who are not interested with it, it's not boring. But the fact is, it's a reality. All of us have to benefit from this stuff. So when something happens, that is the reason why when there's an infection, we have the mature segmented polys, that number, we call them segmented polys. Then we have the band, which is basically not yet reached the maturity stage, but they are lining in the wall of the live vessels. So it is very important when we evaluate an infection, when we know the percentage of band supposed to be like, let's say, less 1-2%, suddenly we have 12%, 15%. Right away we know something terrible just happened, so as to, because the band are not in large quantity in the circulation. The only condition or conditions with an S that's going to cause the band to be in the circulation is an infection. Or to give you one quick example, so I'm teasing you, not giving an example. Let's say something happened for whatever reason, it's a medical problem, like you have an acute asthma attack, and I'm in the emergency room taking care of you in my office, you started wheezing, and you got the patient a small dose of epinephrine under the skin, subcutaneous epinephrine under the skin. Epinephrine is an example of substance that can cause demagination to occur. Another example that happened to all of us, when we are under stress, we release a tremendous amount of adrenaline under stress. And that can cause acute demagination to occur as well, because epinephrine is the same as adrenaline. That's exactly correct. Epinephrine is man-made, adrenaline is in the blood. Those are crucial things to remember, because somebody may show in the emergency room with a very high elevated white blood cell, and yet they're not infected. They're not infected. But people like me and others with knowledge can tell you what's an infection and what's not an infection, even though the white blood cell count is very high. What is demagination? Or for that matter, what is leukemia? What is lymphoma? And so on and so forth. So this stuff is tricky and fascinating if you know how to differentiate the two. And the same thing happen, some happen, whatever the disease, and there are thousands of diseases, I decided, or other doctors decided, that you should get some steroid. How about that? People are getting steroid all day long for different reasons. Well, steroid, my friend, in case you didn't know, you just are finding out, causes migration. That's right. The medication that causes the most acute form of migration in the human body that dump a lot of white cell and happens to be steroid. Okay, give you an injection of steroid, be it intravenously, be it subcutaneously, be it intramuscular or by mouth. I can raise the level of white blood cell by doing so. That's not the reason it's being done, but okay, you understand that. So the two things to remember: adrenaline causes imagination, steroid causes migration. So those are two things you could put in your back pocket, so you know what to do when somebody presents and how to differentiate an infection and infection. So basically, the value of the white blood cells is to fight infection. That is why it is so crucial that one walks around with a normal number of white blood cells. So when you have subgroup, such as black folks, Ashkenazis and otherwise, Latino folks, and a whole lot of other folks who are basically Negroes, who don't want to call themselves Negro because they want to benefit from the social status of America or whatever other country they're living in. They're kidding themselves, but listen, who am I to tell people what to think, what not to think? But the reality of it, they're Negroes. So no matter what they call themselves, believe me, those folks are Negroes. So therefore, Negroes in general, and the reason why I'm making the point of saying Negroes, you have more Negroes than you have black folks in the world. That's exactly correct. Let me repeat that. You have more Negroes than you have people who call themselves blacks in the world. And they suffer from the same thing. Let them go ahead and benefit from their social benefit, whatever. They are, in fact, medically Negroes. And when we are taking care of them, we know they are Negroes and we know how to approach them. Not to discriminate against them, but we know there are certain diseases that are more prevalent in Negroes and how to approach that. When they present to the office with certain symptoms, the symptoms are different. The physiology is different. This is the crucial point. That is why you have such a mess in the world right now. People are dying. People accept death every day rather than accepting who they are so they can get the proper diagnosis made and the proper treatment. I'm not making this up. This is reality. I'm a writer, and I write books, and I read all day, all night. I know what's going on throughout the world because everything I write, every one of these books covers stuff having to do with the rest of the world, not just America, which is the greatest country God has ever created. Were it not for the greatness of America, I wouldn't be sitting here talking to you in the way I'm talking, and they can't challenge, right? Because that when Val says something, people listen because it is the truth. I have no other reason but to tell the truth. Okay, so therefore, I'm here. I'll repeat what I just said. You have more Negroes than you have black folks in the world. People who now refer to as black. There are much more Negroes, many more Negroes. And the failure for them to accept that, that's their business. This whole concept of people calling themselves black, people didn't call themselves black. It was encouraged. I was here in this great country when this whole movement started. It was embraced quickly because the blackness has a negative activity associated with it, but Negroes, there's not, because Negro race is the proudest race that ever existed because all of us started out in Africa as Negroes. As time goes on, wherever we move to, our forebears move to, things that changes due to all sorts of different factors, but we're Negroes. And those Negro cells and DNAs can be recalled in a second by just exposing a little bit of blood to people who knows what to do with the blood. Suffice it to say, this is crucial medically. Has nothing to do with anybody's preference or not preference. It is crucial because when doctors are preventing diseases, they are, as I said, this 10 pages here. And several of diseases are more common in Negroes than they are in other ethnic groups. So when somebody presents to the office, knowing who they really are is crucial in helping us to arrive at the proper diagnosis. People have different symptoms because people present differently. They have different cultures and so on and so forth. So this is crucial. So therefore then, the concept of leukopenia is crucial. It's crucial because when your white blood cell count is low, you are at a higher risk of infection of all types: viral infection, fungal infection, bacterial infection, parasitic infection, and so on and so forth, because you can't fight them. Because not only the quantity of the white blood cell are necessary to fight the infection, but what your lymphocyte produce is crucial to join in the fight as well. What your monocyte produce is crucial in helping in the fight. Just the antibiotics, just the quantity, that's not enough to fight an infection. You need to be immunocompetent. And the immunosubstances come from different types of lymphocyte, come from different type of monocyte, and so on and so forth. So this is why when you are immunodeficient, you are at a risk of getting multitude of different infections and frankly die from them. Okay? So it is crucial that you understand this concept, so that this is why I said many times, and I'll say it again, it is not truly possible to really provide high quality medical care for any subgroup whose culture that you're not familiar with and sensitive to. You just cannot. You could do what we were taught in medical school, but a lot of the stuff that we were taught in medical school, some of it is real, some of it is really not real. It was for the moment. And the people that were teaching it, that's what they knew at the moment. They didn't mean any wrong. That's what they knew. That's what they were teaching. But don't take that and take it to the bank every day thinking this is all it is. That is not true. You have to keep reading. You have to keep involved so that you keep up to date with the latest knowledge of what's going on. I receive about 18 journals in my office per week. And believe me, I read all of them because I have developed an incredible technique over the years. I won't teach it to you, of course not, on how to read a journal. It might take you 2 hours to read one. I can take me 5 minutes and read one and get the same information that you get in 2 hours. That's my technique, okay? And those things I'll be taking to my grave with me, okay? You say, but why are you being selfish? I'm not being selfish. I'm just being who I am, okay? So, therefore then, it is crucial that when someone presents with a low white blood cell count, you determine what it is. What's the cause of it? Is it because of the person's ethnicity? Or is it because the person is carrying a condition that's causing the white count to be low? That may be your first example that somebody may have, let's say, scleroderma. Somebody may have Sjögren's syndrome. Somebody may have rheumatoid arthritis. Or somebody may have dermatomyositis. I can go on and on. The list is there. There are 10 pages. Or every single one of those diseases that are listed here can be associated with low white blood cell count. That may be the presenting problem. So therefore, then when you see someone, you evaluate them. First of all, you listen to their history. You evaluate them completely by examining them. Then you started sending blood tests to find out what's going on. And then you do a CBC. You do a complete metabolic profile, that is a chemistry profile. You do urine analysis. You do a SED-rate. You do an ANA. You do a rheumatoid factor, depending on the patient's symptom. We don't do these things on everybody, every time everybody presents, but depending on the history they're giving you, that leads you to do different things. Sometimes you add things on after the first batch of results come back. If the white blood cell count come back low, then when you examine the patient, was the liver enlarged? Was the spleen enlarged? Because if the spleen is enlarged, that may be the reason why the white count is low, because large spleen can cause low white blood cell count. An enlarged liver may be the reason why The white blood cell count is low. Of those who were normal, the physical exam was completely normal. It doesn't have to be, by the way. Did the patient have a rash? The eyebrow, were they present or they were missing? The fingernail, what did that look like? Crucial. You could make major diagnoses by looking at somebody's fingernail. That's exactly correct. Look at the rest of the skin. What kind of a rash was it? What did the rash look like? Was there an empty space in the area called alopecia? Or was it complete alopecia areata? All those things. And then now you have all these things. You have to figure out, what do I do with this information? Well, you did all that stuff. Everything is looking all right, but you still have to explain the low white count. So what you do, as I stated, you got yourself an ANA. You get yourself a sedate. Those are the first two things that's going to help you. Because all autoimmune diseases are inflammatory in nature. That's right, the autoimmune / inflammatory in nature. And you cannot have a chronic inflammation of any types, no matter the reason for it, without having an elevated sedate. That's exactly correct. And they are conditioned, by the way. Be careful here. There are conditions that can cause the sedate to be low. I can sit here and give you an hour lecture on that. If you still believe that there is an inflammation in your physical, and based on what you've seen, you examine the patient, and the sedate comes back normal, or for that matter, low, Val is going to tell you, check your fibrinogen. Because in case you did not know, you're just learning out what causes the sedate to react is the fibrinogen, which is the phase 2 reacting protein. This is the phase 2 reacting protein that causes the sedate to react, happens to be the fibrinogen. So therefore, after you've done all that, you still believe you're dealing with a chronic infection, you're dealing with a chronic inflammation, you believe you are, then check your fibrinogen. Because if your fibrinogen is low or absent, the reading of the sedate is useless. Okay? Let me tell you one more thing. The fibrinogen may be perfectly normal. If your sedate, see, I told you I can give you a 2-hour lecture. Your sedate comes back low. But you see this patient has a clear alopecia, a clear rash that look like lupus. And the patient is having, or the patient is having symptom that is look like rheumatoid of some kind, rheumatoid arthritis. Or the patient have elevated lymphocyte. Well, why should the sedate be low? Well, guess what? Okay, if you know enough, you could challenge the sedate by doing this way. The sedate is done at room temperature. Okay? And if you still deep in your heart, based on what you just seen, the history of the exam, believe your sedate should be high. Because you have other indicators that something is going on. Go right back. Are you ready? Take that same tube that you did the sedate that has the blood in it, put it back, do it over, and put it in the incubator. Okay? Put it in the incubator. Now, at the temperature of the incubator, 37 point whatever, bango, your sedate reacts. Guess what disease you just diagnosed? Guess what you just diagnosed by doing this simple thing? By taking the sedate that was done at room temperature that was low, you take this, and you believe clinically that based on your history and your physical, another indicator that this patient should not have a low sedate. Take the tube. Take that same tube that says low, take it right back, put it in the incubator at 37 point whatever. An hour, come back later, bango, the sedate is 80. Guess what group of diseases you just diagnosed? My friend, you just diagnosed cold agglutinin diseases. How about that? Which is lymphocytic in nature. And the reason why you're able to do that, because you're smart enough, When you look at your differential, you were seeing a lot of atypical, bizarre-looking lymphocytes. Something is wrong. You just diagnose a series of diseases that can cause people to die from lymphoma, another lymphoproliferative disease called cold agglutinin. By doing that simple process, by taking the cigarette tube that was normal at room temperature, cold agglutinin means that they don't react when the temperature is cold like this. Take it and put it in a room environment in the incubator, bang, go, your cigarette shoot right up. You just, right now, probably going to save somebody's life by just something this simple. No $1 trillion machine, just that knowledge. You just diagnose a series of diseases called cold agglutinin diseases. And then you follow the path to reach at that diagnosis, and then bango, you're about to save somebody's life from a malignant type of lymphoma or whatever other problems that are associated in cold agglutinin diseases. You see how simple that is? But it's really not simple. It has to do with knowledge. Knowledge is power. I couldn't care less what anybody else tells you. Knowledge is power. You could have money. You could have political know-how. But if you don't have knowledge, man, you're not powerful. You just pretend to be powerful, okay? Therefore, then, when you do these things, you have to follow through. You have to understand why you're doing the thing. So now you have an elevated cigarette. Then you do an ANA, antinuclear antibody. That's a screening test for several of the bad autoimmune diseases, such as rheumatoid arthritis, such as lupus, a whole lot of other bad conditions. Your ANA will be high. Then you could sort out the ANA to break it down onto ENA to tell you exactly what it is that you're dealing with. Don't fault me if you don't know that stuff. That's your problem. You don't need to know it because you have social and financial power, none of which I have. God knows what he was doing. I have knowledge, you got social benefit, and you have your political power. God, do whatever you want with that. But don't come after me, because I've got to have some. God has to give me some. So therefore then, you do that, and always throw in a CPK. Always throw in an LDH, because the CPK will diagnose a whole lot of abnormal muscle diseases for you. The LDH will diagnose a whole lot of lymphoproliferative diseases for you, and so on and so forth. Okay, I'm going to stop here. Next week, I'm going to continue again to talk about low white blood cell count. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.